This last set of practice problems primarily focuses on content from the 5th module of the course, including interpreting epidemiologic evidence, bias, confounding, effect modification, determining causality, and public communications in epidemiology. The 5th quiz isn't a cumulative final exam, but concepts we've built upon throughout the term will be drawn upon to assess your understanding of the principles of epidemiology I hope you take with you to use in your career. I'm going to read each question and then I'll put up the little pause icon so you can stop the video and answer the question on your own and then continue on at your own pace. A case control study found a strong association between male gender and malaria infection. The odds ratio was 1.8 with a 95% confidence interval of 1.2 to 2.0. You notice when reading the methods and discussion sections that the authors failed to account for outdoor occupation, which is more frequent among males in the country where the study was conducted. In this study, outdoor occupation was likely a confounder. Outdoor occupation occurs more often in males, and outdoor occupation leads to a higher risk of malaria infection, but it's not on the causal pathway. Being male does not increase your risk of malaria. In your textbook, she words the criteria for a variable to be a confounder as needing to cause the outcome, but rather than a true causal relationship, I think it's better to think about it as it has to be associated with. Because if we said that outdoor occupation caused someone to be male, that doesn't really make sense. But outdoor occupation is associated with male gender. If you think back to the examples I used in the lecture about this, similarly, it would be weird wording and somewhat confusing to say that high socioeconomic status causes men to wear silk ties. It would be better to word it as wearing silk ties is strongly associated with high socioeconomic status. So I wanted to bring this up just in case you were confused by that in the textbook. According to Skelly, Dettori, and Brodt, in addition to most other sources, although a confounding variable may be causative, it doesn't have to be. The primary requirements are that an independent relationship between the variable and outcome exists, and the variable isn't the result of the exposure or the result of the outcome. I'll include their article below these practice problems as an additional resource to clear up any confusion that might have been caused by the textbook's description of confounding variables. Which of the following is a type of bias? Loss to follow-up bias, also known as attrition bias or dropout bias, occurs when there's a differential loss of participants during the course of a study, leading to a non-representative sample. This can distort the observed associations between the exposure and the outcome if the reasons for people dropping out are related to the outcome of interest. While some sources classify confounding as a type of bias, it's usually considered a separate entity, so loss to follow-up is the best answer. Cystic fibrosis is a genetic disease caused by a defect in the transmembrane conductance regulator protein, which moves chloride to the cell's surface. This mutation causes mucus in the lungs, pancreas, and other organs to become thick and sticky, so the body can't clear it effectively. Mucus buildup leads to an environment for bacteria to grow, increasing the risk of pneumonia. If someone has 2 copies of the defective gene, they will have cystic fibrosis. A person with 1 defective copy and 1 normal copy of the gene will not have the disease, but will be a carrier. If 2 people who are carriers have a child, the odds their baby will have cystic fibrosis are 25% that the baby will have cystic fibrosis, 50% the baby will be a carrier but not have the disease, and 25% the baby will not be a carrier or have the disease. The defective gene is blank to cause cystic fibrosis. Necessary but not sufficient. You need a copy of the defective gene to have cystic fibrosis, but if you only have 1 copy, you won't have the disease, you'll be a carrier. No one who doesn't have a defective copy of the gene can develop cystic fibrosis. 2 copies of the defective gene are necessary to cause cystic fibrosis. A randomized clinical trial is being conducted to assess the efficacy of a new cystic fibrosis treatment. 1,000 patients are enrolled and randomized to either receive the new treatment or the standard treatment. During the study, the principal investigator reads that preterm infants with cystic fibrosis have a greater chance of premature mortality. He disqualifies 12 of 500 patients receiving the new treatment, given this new information, because he's concerned the patients who are born prematurely may minimize the effect of the new treatment if they have worse clinical outcomes due to their pre-existing condition. Were the investigators' actions justified? Why or why not? The investigators should not have excluded participants after randomization based on the treatment group they were assigned to, because this introduces exclusion bias and will compromise the internal validity of the study. Remember that exclusion bias is a type of selection bias that occurs when subgroups of people are intentionally excluded from the sample after randomization, leading to a systematic difference between the treatment and control groups. Exclusion bias can also be a problem in case control studies if people with a very high or very low rate of prior exposure are excluded from being either cases or controls, but not excluded from both groups equally. The Nurses' Health Study is one of the largest cohort studies on the health of women. Following the original cohort of 121,700 women enrolled in 1976, 2 subsequent cohorts of the study have been enrolled, with the most recent cohort including male nurses for the first time. You conduct a nested case control study within the Nurses' Health Study on multiple sclerosis. When someone within the Nurses' Health Study is diagnosed with MS, you include them as a case for your study and match them to a control nurse in the study without MS at the time of the case's diagnosis. Your colleague expresses concern that most of your cases were participants in the original cohort, while most of the controls were selected from the third cohort, making them about 40 years younger on average. Which type of bias might this difference between the cases and controls introduce? In a nested case control study, selection bias can occur if the cases and controls aren't selected from the same underlying cohort, or if the selection process is influenced by the exposure status. Such differences can lead to a non-representative sample and can impact the study's validity by skewing the association, possibly leading to an overestimation or underestimation of the true effect if one existed. Your colleague conducted a nested case control study within the Nurses' Health Study on the effect of saturated fat intake on the risk of female breast cancer. Her study found an odds ratio of 1.8 with a 95% confidence interval of 1.2 to 2.5 for women in the highest quartile of mean daily saturated fat consumption. How would you interpret this result in terms of the relationship between breast cancer risk and saturated fat intake? Remember that an odds ratio is the odds of getting a disease for someone who is exposed relative to the odds of the disease in someone who is not exposed. The odds ratio of 1.8 means the odds of breast cancer was 80% higher for nurses with a higher intake of saturated fat compared to those with a lower saturated fat intake. Because the odds ratio is greater than 1, it suggests there's a positive association between breast cancer and saturated fat intake, and higher levels of consumption may contribute to an increased risk of cancer. The 95% confidence interval means that if the study were repeated 100 times, the real value in the population would be included in the results 95 out of 100 of those times. Because the confidence interval of 1.2 to 2.5 doesn't include 1, it indicates that the observed relationship is unlikely to be due to chance. So taken together, the study findings do provide support for a positive relationship between higher saturated fat intake and breast cancer risk among the women in the study. Which of the following is the best assessment of the external validity of this study? While having only registered nurses in the study strengthens the internal validity in the sense that it controls for socioeconomic status, It may limit the external validity of the study because we know access to high quality food varies by socioeconomic status. So there may be important differences related to the saturated fat in the diets of nurses in comparison to low income or very high income people. And in addition to the original cohort being 100% female, nurses used to be disproportionately white, so cultural differences in diet could also limit generalizability. Which of the following can you conclude based on the data provided? Non-Hispanic Black people experience a pedestrian death rate 118% higher than non-Hispanic whites. The table on the left shows pedestrian fatalities by race as a percentage of pedestrian fatalities that year. Looking at this table alone doesn't provide information on what proportion of the U.S. population that racial group comprises. From the census data on the right, you can see that Black or African American people are disproportionately killed by drivers based on the percentage of the U.S. population they comprise. For this data, adolescent suicide attempts is defined as the estimated percent of high school students, grades 9 through 12, who tried to intentionally take their own life one or more times during the past 12 months. Which of the following can you conclude about high school suicide attempts in Alaska based on the data provided? We can't conclude that in 2019 there was a statistically significant difference in the percent of students who attempted suicide between Alaska Native and Alaska White high school students based on the data. Interestingly, the Alaska Native Tribal Health Consortium's epicenter that provided this data didn't include p-values or another statistical test with the data, although they did claim on their website that there was not a statistically significant difference between students who attempted suicide between Alaska Native and Alaska White high school students. While it's true that the 2019 confidence intervals of 16.8 to 33.8 and 12.2 to 18.5% do overlap, that's not enough information to really draw a meaningful conclusion about the two groups and make a definitive statement on whether or not it is or isn't statistically significant. It is fair to conclude that the percent of Alaska Native high school students who attempted suicide remained relatively stable between 2007 and 2019. 20.2% and 24.3% are fairly similar. And we can also conclude from the data that in 2019, nearly 1 in 4, or 24.3%, of Alaska Native high school students reported one or more suicide attempts during the past 12 months. When you're looking at data like this, it's helpful to pay attention to trends in the population and put the data into context with what it is you're looking at and what that means for how you're going to use the data. Try not to get too hung up on whether something is or is not statistically significant or exactly what the p-value is, because taking a more comprehensive look at the data is much more helpful if you're doing community program planning or public health work. Hyperlipidemia has been established as a risk factor for atherosclerosis. Some people with high serum lipid levels never go on to develop atherosclerosis, even after many years. How would you classify hyperlipidemia as it relates to the development of atherosclerosis? Necessary but not sufficient, because you generally need high lipid levels in order for plaques to form in the arteries, but just because your lipids are high doesn't mean that you're going to necessarily have atherosclerosis. Apply Hill's criteria to consider whether there's evidence for a causal relationship between asthma and air pollution based on your own knowledge of the literature on this topic. People generally get exposed to air pollution and then go on to develop asthma, not the other way around, so that checks out. Studies have shown a strong association between exposure to air pollution and asthma development. A dose-response relationship has been shown, where people who live in areas with very high levels of air pollution have higher rates of asthma, and people who live in areas with lower rates of air pollution have lower rates of asthma. Findings have been consistent across many studies of asthma. It's biologically plausible that air pollution would cause asthma. That makes sense. Alternate explanations for how asthma develops have been hypothesized and considered. We know that if people who live in neighborhoods with high levels of air pollution and asthma move to places with less air pollution, their asthma control tends to improve. Specificity doesn't really check out on this one because we know that asthma is also caused by allergies, occupational exposures, and cigarette smoking, and it can be triggered by cold weather, emotional stress, and respiratory infections, for example. But as I mentioned in the lecture, that's the least important criteria. And lastly, the mechanism by which air pollution would cause asthma is compatible with existing knowledge. So I'd say it checks out. Wu and colleagues in 2010 found that obese patients with heart failure had an 18% lower risk of mortality following a myocardial infarction. Their study included 6,561 participants, 1,573 of which had a BMI greater than or equal to 30, and 4,988 had a BMI from 18.5 to 29.9. Obese and non-obese patients were matched based on 65 baseline characteristics to form 1,519 pairs. They found obesity was associated with reduced mortality, with a hazard ratio of 0.82, with a 95% confidence interval of 0.70 to 0.95, and a p-value of less than 0.0001. What do you think might be going on here? In this real-life example, the paradoxical association between obesity and lower mortality disappeared when the data was adjusted for age. Wu and colleagues found an age-adjusted hazard ratio of 0.91 with a 95% confidence interval of 0.78 to 1.06 and a p-value of 0.008. People who have a heart attack at a young age are more likely to be obese. And people who are younger when they have their first heart attack are also more likely to survive. But obesity does not provide a protective effect. Age does provide a protective effect. So obese patients had a lower mortality risk because as a group, they were much younger than the non-obese patients who tended to be older, because heart disease is more prevalent in elderly people. Confounding occurs when a comparison is made between groups that are not similar in ways that affect the outcome. Infant mortality rates 7% above expected were observed for several months in 2022 and 2023. A study by Gallo in 2024 found that about 80% of the excess infant deaths observed following the Dobbs decision, which overturned Roe v. Wade, could be attributed to congenital anomalies. Does the increase in infant mortality rates following Roe v. Wade being overturned due to more infants being born with congenital anomalies reflect confounding or effect modification? This isn't a straightforward one, but here's how I started thinking about it. In general, infant mortality rate is a function of fertility rate for a population. Infant mortality rate is definitely our outcome in this scenario. I wasn't totally sure if the exposure should really be pregnancy or fertility rate, but because we're looking at the population level, I think fertility rate makes more sense. If we imagine a population where the fertility rate is remaining constant through time, and then the Dobbs decision occurred, so access to abortion decreased, then pregnancies that would have normally been terminated due to congenital anomalies were carried to term, which resulted in an increase in the infant mortality rate. So abortion access is acting as a modifier because the degree to which a population has access to abortion modifies the infant mortality rate even when the fertility rate is assumed to remain constant. Remember that a variable is an effect modifier if the strength of the relationship between the risk factor and the outcome differs with differing levels of that variable. Or put another way, effect modification is when the treatment effect varies by stratum of another variable. And we can check for effect modification by stratifying the population by a covariate and then comparing the effects in the subgroups. So if we were to stratify communities of women across the US by access to abortion, I hypothesized that our data would show a modification of this effect of increased infant mortality rate due to more babies being born with congenital anomalies. It's been a pleasure being your instructor for this epidemiology course this term. I hope you've gained principles of epidemiology that you can take with you in the future, wherever your career may take you. Public health careers take many forms, but the tools that were taught in this class can be applied to many different settings. I'd appreciate it if you fill out the course evaluation. I really value your feedback, and I'll use your input to make this course better if I have the opportunity to teach it again in the future at UAA. Thank you.